All right, first and foremost, a little housekeeping. Can we give a quick round of applause for TOA, who provided all of the lunch and food today? A couple things before we introduce our speaker today, a couple housekeeping things that none of these should be a surprise to anyone. Remember your vacation carryover. We're getting towards the end of the year. Some of you guys, hopefully everyone's aware of kind of where they're at, what their balances are. Also, remember when you're kind of calculating some things, remember you will be earning time in December. So as of the 21st, which is the end of this week, everybody earns another vacation day. So be sure to kind of calculate that in. Be sure to get, if you're carrying over any excess of what you're allowed to carry over, be sure to send those pieces of paper up. I think the deadline is next Thursday at 4 o'clock. I believe that's right. We like to have at least a day to kind of get them organized and get them up to the mayor's office. All right. Any questions over that? The kind of along the same lines, for those of you that have earned them, your wellness day that everybody should have earned if you were eligible to earn it back in May. Those of you that have a safe driving day, those of you that have earned a safety day, which is a lot of you this year in July, all of those days have to be used by the end of the year. So those of you taking off next couple days or sometime next week, play it smart. You're allowed to carry over vacation time. You're not allowed to carry over those days. So be sure you're using those days by the end of the year if you're taking any time off. So last but not least, if you earned a new focus day, which was part of the 3 out of the 4 events that you had to hit for this year's wellness program that we just finished at the blood drive. If you have no idea what I'm talking about, you're either unaware or you probably did not earn it, because if you did earn it, you have been notified by our office. Those will be loaded around the first of the year because you're not supposed to use them until after January 1. That's why you may not have any idea what I'm talking about yet. So very near the end of the year, we'll load those in the system for those of you that have earned them. And you'll have, Shelley, is it 6 months to use it by the end of the fiscal year? So come see us if you got any questions over any of those. Other than that, I'll start the introduction for our speaker today. Dr. Brian Cook joined TOA in August of 2004 following the completion of a 1-year sports medicine fellowship at the prestigious American Sports Medicine Institute with the world-renowned Dr. James Andrews in Birmingham, Alabama. Dr. Cook is a shoulder and knee specialist with special interest in sports medicine, minimally invasive arthroscopic surgery, joint replacement, fracture care, and workers' comp injuries. He's also got a pretty awesome mustache. So, without further ado, please help me welcome Dr. Brian Cook.
Greetings. How do I, when I switch through slides, what do I press? Gotcha. Okay. Yeah, thanks for having me. Get a good look at the stash. My wife's done with it, so it's going to be gone by next week. Had it for like a year. I mean, it's a record, but good. Well, I appreciate you having me. I was asked to talk about some, I mean, this is really basic talk on some shoulder and knee issues, how I treat them, maybe ways to try to help with, certain body mechanics and things to try to help prevent some of these things. We can have this be however. I've got some slides and show some things. If y'all have questions, you can ask me as I go. We can talk at the end. I mean, this is really kind of designed just to give you all information and be really a very informal thing. I didn't know I was getting an introduction, so I have a couple slides that would introduce, but we can kind of skip through a couple of those. I'm not from here. I'm from Toledo, and I did see an Ohio State something. OAIO. That's right. Yeah. All right. So it was the Ohio State University is what it was called when I was there. E. Gordon Gee was actually the guy that came up with that. That little, I don't know why he called it that, but he ended up coming to Vanderbilt after that, and then went back up. But I was there, went to University of Wisconsin, was with Dr. Andrews, and have been here for about 14 and a half years. And yeah, so what I do is mostly knee and shoulder conditions and some joint replacement. I live here. My wife and I live not even 2 miles from here. My kids go to school here. We go to church here. I mean, we and I'm staying. I mean, this is, so I'm really, being in Hendersonville, Sumner County is something that we've really kind of invested our lives into being here and serving here, and I'm happy and proud to do it. All right, so, we'll talk about some shoulder type things. The shoulder joint, on the right, we got the bony structures, on the left, the muscular structures. The interesting thing about the shoulder is that it creates a greater range of motion than any other joint in our body. And the complexity of all that really sets it up to potentially have a few more injuries in different ways than some others. Looking at the right, you got the sort of, is there any a pointer at all? If not, no big deal. But there's sort of like you got your ball and socket joint is kind of the main, that humerus and scapula. They say that it's so far away, it's a little bit hard to read anything, and that doesn't matter anyway. But you got your collarbone kind of runs across, which is we call your clavicle. And then the shoulder blade is a really complex bone in and of itself and has complex. All right, we'll see if this works.
Try that, see,
Yeah.
Push that button, see if you can lighten. Hang on.
Well, that's all right. It's too far. No big deal. But it's really so you got some bony structures that can be involved with injury, and then you got all your muscular structures. Looking at the right, the biggest one you hear, your pectoralis major runs across the front of your chest, your deltoid, your biceps, etc. So there's a lot of different kind of muscular structures that sort of cross and work in different function, different ways that potentially could get set up for injuries. The rotator cuff, some people, I've heard patients call it all sorts of things, rotor cuff and whatever else. It's basically, it's rotator cuff, which means those muscles are designed to help your shoulder rotate, and it forms sort of this cuff of tissue around. So looking at the right is sort of the front, and it's kind of made of 4 tendons. There's really 3 main ones. The front, the subscapularis, is sort of the tendon up front. When you look at that picture, there's that little groove that sits right next to it. That's where your biceps tendon runs up through. So biceps and rotator cuff problems kind of go hand in hand. And then the tendon kind of sitting behind that, and then sort of that we call it the super. So that looking at the picture on the left is your scapular, that's your scapula, and then that little bone that runs between is the spine. That's what we call the supraspinatus and infraspinatus, the one above, the one below. The supraspinatus is the one that most commonly does get injured and torn. And there's that last little teres minor. I've never seen a teres minor tear ever, so I think it ought to be like Pluto and kind of get thrown out of the rotator cuff because it just never gets hurt. Ooh, we got another one. That one's not working either. I see red light, but I got nothing. Yeah, it's all right. There's, they're not that exciting to have anything to point much at anyway, but, so, yeah. Uh-oh. Well, we'll see if this works. This doesn't work. We may have it flipping around. I won't be able to see the arrows. Nope. Wait. Well, it goes to the wall, but once it gets to there, all right, you can turn the lights back on. I say these are slides that like probably a 6-year-old could have done better. But so rotator cuff disorders, one of the most common things that I see, and there's kind of 2 main kind. There's you sort of got people will get it. It's one of the most common causes of shoulder pain that I see. One cause is that, there's traumatic ones. There's people fall, someone lifts something really heavy, and those muscles can pull off the bone. When it's a immediate traumatic type injury, those are things that we move forward a little bit quicker and potentially get an MRI scan to see if it really is a new acute big tear. The symptoms and that, like if you have a fall to the ground or you pulling something and all of a sudden you cannot raise your arm at all, and you can't sleep at night, and pain is high and miserable. Those are tears that, when that happens, we kind of need to know about those sooner than later, because the acute traumatic tears are ones that we tend to move forward a little quicker on getting an MRI scan, potentially surgery, because those, if you wait too long on those, can be much more challenging to fix. Probably even more common of the kind of the class of rotator cuff pain that I see is when people will get kind of tendonitis. When people talk about bursitis, what that is, if you look at on those pictures on the left, you see the muscle. There's sort of a space between the bone up above, the muscles down below. Is where this sort of bursa sits. The bursa it's not really a defined sac when you get in there, but it's sort of within this space. It's a bit of the rotator cuff tendon sheath that can get inflamed, and it can be from increase activity. People will say, "Doc, it's just because I'm getting old." Well, 16-year-olds don't get it, so it's a little bit of getting old, but it doesn't happen to everybody. And there's ways I can show you that when in a little bit that I do believe that there are ways through some strengthening and body mechanics that you can really help prevent running into some problems with those and actually help some of these non-traumatic type rotator cuff pain get better without surgery and even prevent it from even occurring. I think a lot of times people end up getting it just because of their how they do things with their shoulder mechanics. So that's one of the more. And then the biceps tendon, which I guess there's not really a great picture of that. It just runs up in a groove between there, and those conditions really kind of go hand in hand. So someone comes to my office, they just say, "Boy, I've had pain for a while." Or maybe they've had a repetitive use situation can sometimes, and I see that more. I guess it'd be maybe more in people that are doing just repetitive things overhead, and they just kind of have some soreness. Wasn't a specific traumatic one-time thing. We try non-operatively to get them better. A lot of times I'll try initially one like a cortisone type injection into that bursal area, and then we do some physical therapy. And the physical therapy focuses on working on getting your shoulder blade mechanics and alignment correct, and then working on the strengthening of your rotator cuff. And I would say 80+% of people that come in that have some form of rotator cuff pain, that it was not a fall traumatic type injury, we can get better with this. We don't even have to start talking MRI, surgery, that type of thing. Those that don't get better, or those who maybe have had one of the, where you fall and you've got this big, just acute tear, sometimes we have to fix. I do really, I'd say these days about 100% of these arthroscopically, a couple small incisions. If what that picture on the right shows kind of a little bit of a diagram of what it kind of sort of looks like when you get in there. I'm basically passing stitches across that tendon with some anchors and just taking the tendon that was pulled off the bone and reattaching it. And done with, if you particularly on an acute tear, done early when it's not a massive, the whole tendon pulled back, actually do very well. The downside is you got to be in a sling for 6 weeks after surgery, and it takes probably 4 to 6 months to entirely get well, but you ultimately get success. So the way you avoid those is don't fall. It will. That's a good question. So the goal of the surgery is to take that tendon and put it back where it's supposed to be. But with anything we do in the body, your body has to heal that, and your body has to make that weld back down. So those anchors hold it there till your body can heal it, which is why we go sling 6 weeks. We don't let you do much. We protect it. But those anchors, and the same applies to plates and screws, the other things we put in the body, those are designed there just to kind of get your anatomy back to where it's supposed to be so your body can heal it. And if your body doesn't ultimately heal that will fail once you start using it. But that's why if you get them if you get them, soon, before there's tension on them and retracted, you really have a much better chance of getting them to heal. There's this other kind of category of shoulder issues that sometimes people will come to me with that they call them slap tears or labral tears. SLAP is a kind of I guess you'd say an acronym. It stands for superior labral anterior to posterior. Basically, the labrum, as you look in the picture, the top right, is the glenoid means your socket of your ball and socket. The labrum is just cartilage that goes circumferentially all the way around. The biceps tendon attaches up at 12 o'clock, and then you just kind of think of it, we just see it as a clock face, 3, 6, 9, 12, all the way around. And I hear you get all the time radiologists reading slap tears and so on. I mean, a slap tear, which means that's that top of the labrum where the biceps tendon comes in. Sometimes those, when they're torn, are things that we fix. Much more common in younger people. Basically, you get age 40 plus, and I'm not calling that old because I'm in that category still as well. You get 40 plus, there will be, almost everybody has a degenerative type slap tear that when that happens, those are not ones that automatically need surgery. Some of the traumatic ones do. when you can get a labral tear that may require surgery for would be if you dislocate your shoulder. That's probably the most common thing. I see that much more common in younger people and kids when they fall. Some of the athletes, when they fall and their ball comes out of the socket, it can pull that labrum off. In that case, in the young people, if you don't fix them, they have a much higher chance of their shoulder coming out again. Seems to be in I would say the majority of people in this room, if you fell and dislocated your shoulder, you have a higher risk of tearing your rotator cuff than you do tearing your labrum. It's much more, that's a thing of younger people, but it's, people into their, teens up to maybe 40s. As you get older than that, you tend to tear your rotator cuff if you dislocate. So I treat these initially like I do with a rotator. You're trying non-operatively, see if you can get the pain better. Ultimately, if that and I would say that picture on the left probably is really something that's unstable and may need fixes. The repair looks like what it is on the right. I put a couple anchors in that bone and past stitches and sew that back to reattach that where that needs to be. But so that's sort of another category. Fractures. These things they're just accidents, falls, car accidents, stuff like that. Like that picture on the left is a collarbone or clavicle fracture. The picture on the right is we call it proximal humerus. That basically that top part of the humerus that gets broken and is in. You can see several pieces. On either, I would say probably 80 to 90% of fractures don't really always look this bad, and you can treat a lot. I treat a lot of those just if they're lined up reasonably well, will heal and do okay, and don't need surgery. Ones that look like probably either of these. I would say probably do need surgery. If you're treating non-operatively, you go in a sling like the guy on the left. But if you got to fix them, these can be big surgeries. You got to, plate and screws to put all those back together. The really bad ones, you almost have to do a shoulder replacement like that on the right. Whoa, All right. Ooh, I got out of the. How do I get back to Connor? I got out of my slide mode. I am like a low-tech guy. You guys may be way more awesome. I can flip through. If you don't know how to do it yourself, you bring somebody with you that knows how to do it. That's the. I could have my kids here. They would definitely know how to run this stuff better than me. So, sometimes so that the way. There's no way. The way you don't get in a car wreck, you don't fall. But there's no. These things happen. They're accidents. They do. Unfortunately, sometimes they need big surgeries to fix them. Arthritis. I'll see that at times. People come in on a workman's comp issue, and I'm actually not that infrequently, and rarely is arthritis from a work-related thing. You can aggravate an underlying arthritic joint. Basically, arthritis, and in the sense we're talking about here, is when the tread wears out on the tires in your joints. Can be your hip, your knee, any joint in your body, your shoulder. And in this case, let's say someone, they pull it on something, their shoulder hurts, they come and they see me and they have an x-ray that looks like that. I can say, yeah, what you did aggravated that. What you did not cause that bone-to-bone situation. Ultimately, in those, I guess, you would talk about treatment. If that gets to be where over time it's not getting better without surgery, you got to replace it. And that's what I've got a guy, I think, in recovery room right now. I just got done doing a shoulder replacement. So, I think with this, I think, the prevention is what, I think with talk about any problem in life, the best way to, deal with the problem is just avoid it if you can. Avoid falls. Sounds easier than it is, but you would not believe how many people come to my office from simple falls. With shoulder, and shoulder issues one, but just a number. If people didn't fall, then the number of things I would do would be a lot less. But you want to avoid them. So, but in general, and I tell you, really particularly for shoulder issues and the knee, and so really this part really applies for the shoulder and knee issues. That I can't emphasize enough your posture and core strengthening. Because I would imagine most people, core strengthening is, and I'll show a few. You probably know what that is, but it's maintaining of your kind of your main truncal abdominal musculature of improving that, of just across any joint. People say, well, what can I do? A lot of times I'll people who maybe have arthritis or any other problem, what can I do to make this better? Well, you can strengthen the muscles, you can keep the muscles flexible around any given joint that's sore, and that will take pressure off of that joint, whether it be the knee, the shoulder, whatever that is. Weight loss, I mean, it makes sense. I tell you, but, maybe not as much in the shoulder, certainly in the knee. With every single step that you take, you're putting, particularly if you're going upstairs, you're putting 3 to 10 times your body weight force across your knee joint, particularly your kneecap joint. And you think if you lose 10 pounds, 20 pounds, whatever that is, and you think about if you carry around all day a 20, 30, 40-pound backpack, and if you were able to take that backpack off, how good everything ultimately would feel. And I was 40 pounds heavier than I am now, maybe X number of years ago, and I can tell you everything in my body feels better. So I mean, I can tell you it works, and a lot of those things get better. And then other things, people don't always think about your diet. I truly do believe in kind of the sort of anti-inflammatory diet. I think that in a conjunction of losing weight, I think the keto diets, the paleo diets, I'm not a nutritionist, but I can tell you that what you eat and what you put in your body makes a huge difference in how you feel. I think sleep is underrated. I think probably the majority of people don't get enough good, adequate sleep and drinking enough water. So we talk about, so I mean, you look at that person on the left, that looks like probably each of my teenage daughters when they come in. Probably most of us do, and I've said that, they just kind of, and I can't time it, I'm like, sit up, and they're young, they don't have issues, but you can see all the issues of when your core is strengthened, your shoulders are back, and it's not like you have to stand around like you're at attention all the time, but you can see how that picture on the left is that when your shoulders are slumped and you're kind of slumped forward, how your shoulder blades come forward, these sort of things that cause shoulder impingement all on top of the rotator cuff. There's a lot more forces on top of that in that position, that when you compare that to the position on the right, and that's more of your position, a lot of the kind of the rotator cuff impingement issues can really be made better and go away. And that's what a lot of the rotator cuff rehab and therapy, in addition to rotator cuff strengthening, focuses on that. I get into that position on the left all the time. You guys probably know. I mean, I would break something if I did that. But anyway, the things that people like us can do, you can do planks, you can do scissor, you can do crunches. You just do and you find a program that works for you. And I can tell you that it works, and it just will improve really everything. I tell you, it's amazing when I'm getting kids over their ACL reconstruction, how much more anymore I'm emphasizing the core strengthening part of it, and as part of the rehab. Muscles are this old rotator cuff. You can see how fun doing those strengthenings. See the guy on the left, that he's having like a blast there doing his rotator, and that's about how fun they are. But you don't have to do them for like days and days. But they really do help and get you over shoulder problems. And if anybody that picture on the right, if y'all don't have one, you really ought to, in my opinion. I tell people out those foam rollers. People ask what they are. It's like a big cylinder, sits on the ground. You can roll out your back, your shoulders, your legs, your IT band. I have one at home when if I'm going to go be doing certain race or whatever. I take one in my bag and pack one with me. Those things work great. You could if you want to know how to do it, you can go to therapy. You can pull up on YouTube how to use those. They'd cost like $15 or $20 from Walmart, Amazon, whatever, and they are great devices that can really improve your flexibility throughout your body. And again, I think I just put this slide in to remind that keeping in mind what you eat can have sort of an anti-inflammatory effect, plus with a weight loss diet, and then sleep and hydration. Do you have any questions about anything shoulder-wise? If not, that's fine too.
Can you talk a little bit about the shoulder blade and all? There's like 20 connector points or something back there.
There's a lot of connector points. Yeah, I could bore you to death with going through each and every one. Well, basically, your rotator cuff muscles start off of your shoulder blade, and then you have you've got a whole row of across the middle of your back shoulder stabilizing muscles in addition to your trapezius and your latissimus in the back. And so it is, and basically off of your shoulder blade. I mean, the shoulder blade is basically the socket of your ball and socket. So when your shoulder blade's out, that's changing the alignment of your ball and socket. The shoulder blade, the top part is called the acromion bone, and that is the sort of the top of the arch where the rotator cuff comes under. So as your shoulder blade's rolling over, that arch is rolling over and can also cause some rotator cuff issues. But yeah, and that's where, because people say, well, my job's active and I work out a lot and I can, I feel like I'm pretty strong, and those things are probably true in a lot of people, but sometimes it takes a few visits to a therapist to really be able to kind of be shown how to work some of those deeper scapular stabilizing. We'll just refer to them as those because you don't need to know all the names of all those muscles, but to be able to know how to work each of those muscles, to be able to really almost realign that shoulder blade, which improves your posture, can improve a lot of rotator cuff issues. And I really think if the majority if people knew and worked on those and did those, I think I would see a lot fewer shoulder problems in my office. Yeah. So I'll talk a little bit about knee issues and things. General anatomy of what the knee, bony and not bony, looks like. There's, when you look at the picture on the left, there's the thigh bone up top, which is the femur, the tibia bone, which is the bigger one on the bottom. There's that little fibula bone off to the side there. But the main articulation of the knee, which is more of a hinge type joint, with a flexion, extension, and it kind of rotates a bit too. And then some of the ligaments that help stabilize the knee. You've got your ACL and your PCL, which stands for your anterior and your posterior cruciate ligament. You hear of athletes injuring those all the time, and they do. And then your kind of side stabilizing ligaments, your medial and your lateral collateral ligaments, and then the meniscus cartilage, as you can see in that medial and lateral meniscus. That's like you can't really see it. It's a C-shaped cartilage that sits between the bones, helps protect your knee joint. That's why it was put there and designed there. But it's certainly, with the mechanics of the knee, those are really prone to injury, and I do see a lot of meniscus and ligament type injuries and tears. So that the muscular kind of envelope around that, and you see there that they show the kneecap, which kind of sits out away from that, and then the muscles all along the top are the variety of quadriceps muscles, your quadriceps and your patellar tendon or ligament, and then just some of the other soft tissues around that help support the knee. When people talk about they have a meniscus tear, that's showing what I just kind of, if you're looking at a cross section kind of from the top down, there's a variety of different tears that can occur just from a variety of forces, I would say. And again, these, like some rotator cuffs, some of these can be degenerative just with time. That cartilage just ages like we do and can be a little bit more easily torn with lesser injury. But a lot of times those are from a compression, like a squat, pivot, twist type injury. How you do things, sometimes you can maybe help prevent those. Just sometimes they just happen. People, they have their foot planted and twist, and all of a sudden say, man, my knees hurts on that. And so you can sometimes tear that. And a lot of times the little splits, like the one in the top middle, or really the middle bottom, which are kind of I see probably the most frequently. They act like little hangnails inside the knee, and they'll just, normal walking, a lot of times people won't have, but if you go to squat, pivot, twist, or catch your foot wrong, and people say it just kind of feels like this little just kind of knife, just kind of stabbing and catching you. And the way, ultimately, if they're not getting better with time, I treat them, you can do a knee scope, and you basically trim off that little nub, like you would a hangnail, and smooth it off, and it tends to work. You don't go in and remove the whole meniscus. Sometimes if people get the bigger ones, like on the right-hand side, those bucket handle tears, if you have to take those out, you lose a little more meniscus, maybe have a bit more chance of getting arthritic down the line, but we try not to do that if possible. But if you got a meniscus tear that is not getting better, then yeah, it's a knee scope type surgery. It's about a 20-minute outpatient arthroscopic surgery. Most of those aren't really amenable for repair. The meniscus tears that I fix a lot that are really more usually when younger people that tear their ACL that also have a meniscus tear that but really kind of more people in our age group that get those, you go and you trim it out, and really the recovery is fairly quick. Ligament injuries, can happen at work. I think, you hear about a lot of times, and I by far the majority I see probably occur in athletes. It's usually a pivot twist. They're usually non-contact, although they can be contact, but, something like with the guy on the right, and that's, you plant your foot and you twist, and then that ACL can tear. The ACL, you can also, there's other ligaments, but by far what I see with those types are ACL tears. There is a gentleman with y'all that recently did that. I'm going to be fixing soon, but and he unfortunately did it last year as well. I think he retore it, but so it can happen. It can happen at work, but again, it's an accident, something that can happen. When you tear your ACL, it's an ACL reconstruction. I make a little drill tunnel. The picture on the left is kind of what it looks like. I drill little tunnels, pass a graft, put some kind of fixation. I usually use screws in there to hold it in place. Sometimes if they're just a little side ligament injury, you can treat with a brace and let your body heal it over time. Nothing. The other, I guess, category of injuries would be muscle and tendon injuries. Tendonitis, very similar to the shoulder, can be overuse type things. I think the ones that I see that are a little bit more severe and significant would be from a direct fall. Someone falls and directly lands right onto their knee. That's when I see sort of the quadriceps or patellar tendon tears or a patellar fracture. It's pretty rare to get a tendon rupture of the knee from just kind of from a low energy type thing. Usually it's some kind of fall or some kind of a little bit more of a violent force and a traumatic event. But like a rotator cuff tendon, you have a significant fall, and that's when I see them, and they do happen quite a bit. You have fractures that, again, from falls or car accidents. And these can be bad. Obviously, each of the ones that look like that, the one on the left is a kneecap or a patellar fracture. The one on the right is, we call that a tibial plateau fracture. Those are bad. You don't want that you don't want to have an x-ray of your knee looking like that, because what you end up getting is something like that, is where you get this smattering of plates and screws trying to put everything back together, but that's a near guarantee that knee's going to end up in arthritic at some point and stiff and sore, and those are just those are injuries you don't want to have, but nobody asked for them when they woke up that morning. Usually it's something bad, a fall, a car accident, falls off ladders. And similar to the shoulder, arthritis is not really a work-caused situation. I suppose in the one rare instance you end up with a fracture like what the guy had X number of years. If that occurred at work years down the line and he got arthritis, that's one where I would probably say, yeah, I guess maybe that was from a work-related, but majority of the time it's not. It's just you can aggravate. And arthritis, again, is just the cushion on the ends of the bones is wearing out, the tread's wearing out on the tires. Normal pictures on each of those on the left, the arthritic when it wears out bone to bone on the right, and when they get to be bad enough and aren't better with other things in time, you end up replacing them. And picture of this guy here, I think that was Jay Love rolling on a foam roller, but no, this kind of encompasses all the things that stretching, strengthening, core strengthening, fitness, keeping your body weight down. I think each of those things are so important to try to prevent, but things happen. Accidents happen. That's just true with us and anything in life, and when they do, you deal with them and take care of them. So I think just final thoughts in general on this, a lot of sort of basic things in a brief time is, not all these things can be prevented, but, if you focus on, I think if everybody through diet, exercise, weight loss, core strengthening, hydration, all those things, and just general lifestyle improvement and changes, I really think that a lot of some of these types of issues and overuse issues could be made better, quicker, or avoided altogether. I think that particularly, if you're hurt, the other thing is I think when people have been hurting for a long, long time on a certain thing, I think it's harder to get things better. If you've been hurting for a less period of time, I think we usually have a little bit better time of getting things better quicker. And certainly if you have one of those traumatic, and you fall onto your shoulder and you cannot raise that arm and you can't sleep at night, you need to see somebody. And don't let that, because I've seen people come in like 6 months, maybe not where they come in 6 months later and like, man, I've been able to raise my arm for like 6 months, and that tendon could be back retracted and gone and not fixable. And I would think most people would go see somebody, but not everybody does. So that's what I had sort of prepared on these things. Does anybody have thoughts, questions, concerns? Yeah.
How long does a knee replacement last?
Well, because people ask that all the time. It's a good question. Yes. Alice, I've got a friend that, so, what my answer to that is, and my hope is that it's going to be 20, 30 plus years. The real answer is that we don't have the implants that we're using right now, we don't have long-term data on. And what wears out, say, really in any of these, on a hip replacement, knee replacement, shoulder replacement, we'll say a knee, for example, is that what wears out is the plastic. It's kind of a metal. It's kind of a metal on plastic articulation, and ultimately it was the plastic is what wears out, and so what happens is as that starts to wear, it generates these microparticles that your body's immune system sees as being not part of it. Your immune system reacts to it, that then ultimately can affect your bone. The implants can get loose in the bone, then you have to do something. But what our thought and hope is that the implants that we're using now, that the plastic is a better plastic than what, because there once upon a time there was sort of, knees lasted 10 to 15 years. Well, I think what we're using now are much better materials than what they were using when those studies came out. And what we're using now hasn't been in people for 20, 30 plus years. So my hope, and we'll ultimately see, I don't know. My hope is that any joint replacement I put into someone will last their lifetime, and that's the last operation they'll need. Like with most things we do, not 100% thought and guarantee. There's but on people that do end up needing that, I tell you, it is a very, very successful surgery that most people need nothing else done for hopefully a long, long time. And I think we'll be seeing that is true, that they're lasting longer than the implants that were put in, and I guess maybe they started in the 80s. Joint replacement probably didn't. That's about when it maybe historically started. But so, long worded answer to hopefully a long time, 30 plus years, I'm guessing. So.
What about that water? I've heard talk about water. What causes that?
Yep. So when someone says I have water on the knee, what they really have is they have the medical term for that is a knee effusion. What that means is you've got fluid buildup in your knee joint, and that can happen in any joint. You feel it on the knee a little bit more than maybe you would in another joint. What happens in that can be from a couple things, but one, it can be from traumatic. Let's say if you tear your ACL or your patella dislocates or you have a big traumatic, that sort of fluid on the knee could be blood. Because when someone tears their ACL, it's basically the blood vessels in that ligament, it bleeds into the knee, and so that big sort of fluid in the knee is blood. And but I would say much more common, and that would be in the traumatic sense. Much more common would be if someone, I'd say more common someone that has arthritis, but sometimes people have these we call synovial disorders, that the lining of the joint is called the synovium, and that when that gets inflamed, It's what we call synovitis. And so that inflammation can then generate the fluid that goes on the knee. And so that is the sort of water in the knee. And I see that a lot. I mean, people will come in maybe from an injury, maybe from a flare-up of arthritis or whatever, that have that fluid in the knee. And if it's, sore and swollen and stiff, which it usually is, what I usually do is pull it off, put an injection in to try to get that to the injection, which is an anti-inflammatory, to try to get that calmed down. Usually helps and usually works, but that's what they're referring to with the water in the knee. So, yeah.
I had a fall probably 15 years or longer ago, and right on the patella, full body weight come right down on my knees. And now, quite often when I get up, when I usually notice it, as I'm walking, I can hear it popping. I don't know if I'm hearing it,
Yep.
actually hearing it, or if I'm feeling it, but I know it pops.
Yep.
It doesn't do it all the time, just now and then. What's actually happening?
So probably what happened in that sense is that when you fell, you compressed the underlying joint surface on your kneecap and maybe tore the cartilage. And so if that articulation is not just a perfectly smooth articulation, which can happen with the fall, can happen sometimes with age, or if the kneecap is not tracking perfectly in the groove, you'll kind of feel that popping, catching, clicking, that type of thing. So I'm guessing that you probably have a combination of one or two, either the joint surface that is kind of a little bit irregular on that, maybe from the fall. I'm not saying from age, we'll call it from the fall, or if it's just not sitting right in the groove. This is what and with that, I mean, it's when someone comes in with that, I don't say, oh, we need to do a surgery to go and smooth that off. Almost never not. I mean, that's something. If it's something that's just a little annoying and you kind of occasionally get, you just kind of live with it. And if it's something that really is catching, grabbing, is really affecting, then usually we'll start with some physical therapy to try to get through the soft tissue to try to get that where that kneecap tracks a little bit better. But if it's something that's not that big a deal, I just live with it. Yeah. Well, yeah.
I have a couple of questions.
Uh-oh.
First of all, can a frozen shoulder result from neglected strength, and then also the supplements that are on the market for joints and
Yep.
what's your opinion on that?
Yeah. Both good questions. So frozen shoulder almost always is just, it just kind of happens. Nobody knows why. I mean, can you get a frozen shoulder from an injury, from a surgery, or those types of things? I mean, you can, but I would say 90+%, and I see frozen shoulder a lot because I'm pretty much almost all what I see in my office are knee and shoulder issues. I see it a lot. It's usually, but not always, usually women from their 40s to 60s, and it just kind of comes on. And sometimes people relate it to, because maybe once your shoulder kind of gets stiff and you try to relate, man, when did that happen? You kind of think back and you think, well, maybe I kind of remember from when I reached back into my seat to grab something or whatnot. But I would say probably most likely it just came on. And what that is, so that the fancy term for a frozen shoulder, it's when the ball is not moving well relative to the socket. And the orthopedic term for that is called an adhesive capsulitis. Fancy way is, and you're like, but a fancy way of saying, so your capsule or the covering around the joint gets inflamed. So it's the capsule, the itis, so the inflammation of that capsule, and then adhesive, just it's tight. So it's a tightness because of the inflammation of the capsule. Usually from that, in 90+% of people then with that will get better without ever having surgery. So first thing I do, someone comes in that's bothering them enough, we try a one-time injection to get some of the inflammation down, and then we do some physical therapy, and then I follow them in 6-week increments, and if they're just getting better, we let them keep getting better. Those, probably that 10%-ish that don't get better with that, we go to surgery arthroscopically, can do a little bit of a little bit of release of the capsule and release some of the scar tissue and get it better. The interesting thing with that is that there's a lot that nobody kind of knows why it comes on. Nobody really knows. Once it goes away, it never comes back. I've never seen it in both shoulders at the same time. But someone that's had it in one is probably a little bit higher risk of getting it in the other. But then once it's gone, it's gone. It's kind of interesting. So that's question one. So can it be from an injury? It can, but most of the time not. The supplements, and there's a million of them out there. The bottom line is we don't have a lot of science to support any of those. Probably the one I'm asked about the most is the glucosamine chondroitin products. There's a whole bunch of them. They sometimes add osteobiflex, things such as that. Put it this way, if I had an arthritic joint, I would probably myself maybe try that for a couple months. And if I noticed a difference, I would maybe keep taking it. If I didn't notice a difference, I wouldn't. Do they really work? Maybe. And people say, well, is it a placebo? Meaning, is that just all in your head? In my opinion, if you're better, you're better. And if you believe that what you're taking, so long as there's no risk or harm to you, if you think it's getting you better, then it's getting you better. There are, my mother takes black cherry extract for her knees, swears it works. Maybe it does. If she believes it does, it does. I take no medication, but the things I take vitamin D because I believe one time I had mine checked. I don't even know why somebody checked it, but it was low. I have no idea why it was low, so I started taking it then, and whatever I was doing. I take a fish oil. There was this huge craze in taking fish oil. I think it's kind of died down now, but I believe, I'm sure in my head, that it keeps just general inflammation down and that type of thing. So I take one of those each a day. I'm not a huge vitamin supplement guy. I think you could go crazy going to, it could drive you insane if you researched all the different things and went to either GNC or Vitamin Shop or online. You could, anybody, and the thing is, the majority of that, since we don't have the science, if someone's really trying to sell you something, they're trying to sell you something, and there's not a lot. And so I don't know. I'm not huge. I know that the rage right now, I'm not saying I support it at all, is this the CBD oil. I'm not saying I'm against it either. It's this sort of the it's basically derived from the cannabis oil, and I have people that swear by this. It's legal, so that it doesn't have the THC or the hallucinogenic effect, and it's actually legal here in Tennessee, and I have some people that use it, and I don't have any evidence, science, anything to support that, but if it can't hurt, and in general terms, if something doesn't have side effects and can't hurt you, it's not prohibitively expensive, and you try it, and if it really is making you better, there's no downside to doing it and trying it. But I don't endorse a lot of that stuff because I don't know. I think probably most of it is a little hocus pocus, but so. All right, well, I've probably gone way over. I didn't even check the time. Probably went way. I'm sorry. If I went over time, I apologize. But I appreciate your all's attention and having me. So.
Has everybody signed in today that's in the class currently? I guess so. Okay. Well, first I want to thank the City of Hendersonville for allowing us to participate in your wellness program today, and we have at TOA we're offering a $25 gift card to someone who signed in on this list. Dr. Cook, would you like to pick a number between 1 and 36?
15.
15. Chris Taylor.
Oh, great.